Hello and welcome to Mental Health Consult. I'm Whitney McKnight. This is my co-host, Dr. Lorenzo Norris. And you're probably a primary care physician who has seen a lot of mental health issues present in your office. And as we move away from fee-for-service toward value-based care, this is becoming more important that you feel comfortable in treating these kinds of patients because you are being evaluated on your reimbursements about these things. We have with us Dr. James Griffith, who's the chair of the psychiatry department at George Washington University School of Medicine. He also sees patients in private practice, and we are also joined by Dr. April Barber. Dr. Barber is the head of general medicine, and she also has patients that she sees in private practice. And what we're going to do today is, in about the same amount of time that you will have to see a patient, we're going to take 15 minutes and we're going to address the case that Dr. Norris is going to tell us about right now.
Well, thank you so much, Whitney. In this case, we have Natalie, who is a 42-year-old female with no previous past psychiatric history, and she has a past medical history significant for diabetes and hypertension. Natalie is coming to see her primary care clinician just in terms of her annual visit, and in that visit, symptoms of depression are uncovered on interview as well as off of a PHQ-9 screen. Mm-hmm. So Whitney, one of the things with this case is how do we approach a patient who may have overt signs of a clinical depression, who could potentially benefit from medications or not, but has a certain level of ambivalence about trying the medications, and is also asking the clinician some direct questions in regards to the efficacies of these medications. In addition, the patient also feels as though she has a number of coping resources that she can already utilize. So, Whitney, this is where we're at.
I think we should start with the primary care office then. So what are you thinking when you see this patient come in, April?
Well, I think always I would want to rule out medical issues and problems. When I feel like someone's depressed, some of the things I want to make sure, particularly if I'm thinking about a medication, is this woman is 42, she's of childbearing age, is she thinking about becoming pregnant, could she be pregnant? Those are things that I always want to review. And also then just delving into the history of her depression. Is this the first time? Has she had this before? And I think the things that I worry about are missing bipolar depression. That would be something I would want to definitely screen her for.
At that late, that would be the first time it would present? There wouldn't be a history where you could look at that?
There may be. I would definitely ask about that to see. If this is the first time I'm seeing her, I may not know her history from before.
Right. So Dr. Barber, I heard a couple of things there. One, concern for pregnancy. Second, medical conditions or medications. The patient has a history of diabetes or hypertension. We didn't elaborate on the patient's medication history, but that's something you could think about.
Yeah.
So those are important points. Dr. Griffith, what are things that you're thinking about when you first read the case?
Well, several things. One, hypertension, diabetes. These are two illnesses where adherence is important. With depression, you tend to get poor self-care, exercise, diet, and so forth, as well as poor adherence to medications. So keeping an eye on the interaction between the depression and also the care for the medical illnesses. The other that jumps out is her stage in life. She's 42 years old. This is midlife. And thinking quickly, just about some of the big points, one of the problems with depression is the fact we have medications called antidepressants, giving the impression that, like an antibiotic with an infection, you take this and it takes care of the depression. These medications actually do not work that particularly well unless they are also coordinated with other non-pharmacological things that will help a depressed mood. So at age 42, you expect that life is changing. Things that have been more gratifying in the past may not be now. She is in an intimate relationship. Depression is very sensitive to the relationships. So just right off the bat, I've been thinking about things, there's a brief therapy for depression called behavioral activation, and the heart of that is just having a conversation with somebody about in rank, next most, what makes life rich for you, and working with somebody to put more of that into their life. Very sensitive to relationships, so I want to have a conversation about where are things now in your couple relationship. Are they changing over time, and are there things they are not talked about that would really benefit perhaps more of a couple focused therapy? And one thing that happens at midlife is you take stock of your life, you see what you've accomplished, you see how many more years you may have, and the question of what is my life about really becomes very important.
Can I stop you there and back you up then? So have you already in your mind diagnosed depression, or are you still looking at there being a differential, maybe being just that it's, as you've talked a lot at length about in your career, distress? What are your differentials in this case?
Well, the measures I was taking would be things I might do with both. But in terms of distinguishing between unhappiness, loneliness, kind of loss of meaning, spiritual crisis, the big things you look at are loss of adonia. If there's something good happens in your life, are you still able to enjoy things? If you lose that, it tilts toward depression.
Okay.
Loss of self-worth, self-regard tilts toward depression. I'm using that because it's a little bit like in the law where you want the preponderance of evidence, meaning 50% likelihood, because these are not foolproof. Certainly if there's any suicidal ideation, that tilts to depression. Things like poor sleep, low energy, don't discriminate well. Just difficulties in life generally will impair those. So what I would do would be listening closely for these, but in my practice, every single person I see where there's a question, I do a formal, quantified, validated instrument. The one I do in my practice is a Hamilton Depression Scale.
The large one or the smaller one?
I do the 17 item. But for in family practice, family medicine, general internal medicine, I think people probably would rely more on the PHQ-9, which you can download off the internet.
Yes.
Patient fills it out themselves.
Could a primary care physician use the Hamilton scale?
Yes.
Okay.
I mean, it's similar.
Big
greater
sigh.
validation, but it takes time.
Yes, that's
it takes time.
Yes, and
I just think back to past years. There was a Dr. Frank Degree when he was chair in South Alabama family medicine. We presented together, and he said, "Your primary care visit is 9 minutes, 5 items on the problem list." And if you have anything like that, you're going to use a shorter.
Okay.
All right, and Dr. Barber, with that being said, in regards to the use of scales, this is actually an important point. In this particular case, a PHQ-9 was used, and obviously this is an evidence-based scale that has been used in a variety of situations in primary care with those with comorbid medical illness. Is there any particular scale that you routinely use in your practice?
We use the PHQ-2 for screening, and then we'll use the PHQ-9 for a positive screen.
All right.
We do it probably not as routinely as every patient that screens positive, but I think it's becoming more and more helpful. And we use it to monitor treatment as well, and how people are doing over time. So I think that's where it helps us.
So what is Dr. Griffith saying that you are thinking, well, I don't do that, that's different than what I would do in my primary care setting?
As far as how he would assess the patient, I think those are things we would definitely assess and talk about with the patient. Yeah.
Okay. Well, again, I think it again comes down to time. It depends on, again, our primary care clinicians anywhere from 9 to 15 minutes. Now, that being said, I've seen my fair share of primary care clinicians extend, if you will, their appointments. But I think to do what Griff is talking about in a more nuanced, calm way, when you look at the tone of your language and even the way in which you approach things, that takes a certain amount of time and effort. So, excellent points. Dr. Griffith, when you read this case, and just in terms of the top 3 things in your differential, and I know this is somewhat of a, just kind of a, it's difficult to put somebody into a diagnostic category strictly because we're talking about the meaning of whom they are. But if you had to pick 3 things diagnostically that were at the top of your differential, what would they be?
In terms of your question, distinguishing distress from disorder, or in terms of opening up areas that we may want to go therapeutically?
Whatever's best for the patient.
Yes.
Okay.
Yeah.
Well, the things I mentioned before, I would go through, because I would want to know, am I dealing with a mood disorder that should be regarded as a psychiatric illness? Framed to the patient that way, and really emphasizing the need for an evidence-based psychotherapy for depression and medicine, or Is it more like demoralization, grief, that what you're going through is what most anyone would, given your circumstances?
Okay.
That's what we mean by distress and not disorder. Having done that, when you think about differential, I would think about what are key areas where it's likely to be fruitful in terms of helping her move to a better mood. And the first one I probably actually would think about would be the relationship. A second one would be is that at midlife, are there fewer gratifying, rewarding experiences than before? But the other, and this is the one where I would think in terms of building resilience, getting ready to face whatever comes down the road, is the question of when you faced hard adversities in your life in the past, what has helped you to get through? What has kept you from giving up?
So reminding the patient of the inherent skills and resilience that they already possess.
Well, I'm listening for the answer. Because people tend to go into one of four directions. It could be others, but for some people, they're problem solvers, so they say, well, when I meet hard things, I start thinking about how do I get through it, how do I plan a path.
Okay.
Most people turn relational. When they meet a hard adversity, they say, who can I talk to, who can I be with?
Okay.
A lot of us, like myself, drop back into some core identity that this is who I am, this is who I'm determined to be.
So that's the third option, is you just go back to who you know yourself to be?
Core identity in my heart of hearts, who do I know myself to be? Who is the person I aspire to be? Who are the people I belong to? Who counts on me? Who do I count on? And then there are people that the first thing they do is to ground themselves, to meditate, to focus on a spiritual way. But whichever direction she goes in, I'm going to guess this is her strong suit for hope, for resilience. So I would work with her to do more of it. If she talks about relationships, then I want to know what is the state of her relationships. Other people have been dropping out of life. Often at midlife, people have fewer and fewer friendships, and they need to be repopulated.
When I hear this and what I'm thinking about in terms of the differential, Griff brought up the idea of mood disorder or mood spectrum disorders, which also Dr. Barber brought up, which, and again, you always want to consider bipolar disorder. Even in this case, I would not necessarily suspect that. Then you appropriately also brought up the idea of, if you will, could this in some way, shape, or form be related to a medical condition, pregnancy, use of medications or whatnot? And then Griff guided us in a very nuanced discussion in regards to demoralization, and particularly the things, if I had to put in maybe two words, loss, how you cope with loss, and how does it affect your identity? If I had to pick those three things, not stated as beautifully as Griff, but things that I think that you can focus on, and when working with a patient or starting that dialogue, that a therapist or a psychiatrist can continue. Now, let's talk treatment. Dr. Barber, what would be your treatment plan for this patient, assuming that we have a preliminary diagnosis of, or working diagnosis rather, of something potentially in a depressive spectrum disorder? Please.
Well, I really like what Griff was saying about that, and that's one of the joys of being a primary care physician, because many times I've gone through some of these things with my patient before, and whether or not they remember what got them through, I can often remind them of that. And so I think playing on that, seeing what sorts of treatment options maybe have worked for them in the past, or where their preference is. I usually offer talk therapy. Do they want to talk to someone? I usually phrase that very generally. If I feel like they're having a lot of trouble functioning, I may bring up medicines. I usually will not do that right away unless I feel like they could definitely benefit from that. But I think it really deserves a long conversation before starting anything like that.
Dr. Barber, before we transition to Dr. Griff and his treatment recommendations, I just want to pause. What you just said, what Dr. Barber just said, I think is vitally important. Even if the patient forgot what got them through, you frequently can remember. I think a very underutilized resource, power that our primary care clinicians can provide because of the longitudinal relationship. And that ability to remind them in and of itself can be very therapeutic. Thank you for bringing that up. Dr. Griffith.
Well, the one important thing which we haven't talked about that's in the story
Yes.
is that she has a lot of misgivings about taking medication.
Yeah.
Another thing that's in the story is that she's relied a lot on her spiritual resources over the years. Now, the two are often connected. Now, when people are not wanting to take medications, if it's not due to cost or side effects, it's usually due to some issue of stigma. But there's a whole family of different kinds of stigma. One that is suggested in the story is moral stigma, the sense that if I take medications, I'm being a weak or unworthy person. There's also stigma about how will I be perceived in my family and the community. Will people not take me seriously? Will they see me as mentally ill and want to stay away? If we were to determine that she has a depression that would benefit from medications, this needs to be a focused conversation. What are her reservations about? If medications have a downside, what are they? Second, just the fact that she's already alluded to her spiritual resources suggests where she may find. I'm going back to our questions about resilience. You know, what carries you through hard times? You've met adversity in the past. What helped you get through? Without even putting anything about religion and spirituality in the question, you will hear about it if you ask that question and a person has a very active spiritual life. But then spirituality means a lot of different things. Does it mean prayer? Does it mean connection to a community? Is it a set of particular beliefs that fall back on to get you through things? And however much time is spent discussing that is going to save time in the long run.
Okay. All right, Whitney, what are you hearing?
I'm hearing that this is a situation for the primary care provider to actually just be a person. To just think, I am face to face with someone who is struggling, and if I can just listen, I might hear the strength that person needs to be reminded that is already within. Now, I would certainly make sure that you've ruled out any clinical issues, but the thing that I'm impressed by, though, with what Dr. Griffith is saying is that these are the kinds of things that don't show up on most screening tools. So you have to actually step outside of the rush that you're feeling all the time, 15 minutes, and just remember to be present and think, okay, what is the logical question? And maybe familiarize yourself with these four questions, that are these four types of coping skills that Griff is talking about. And I'll make sure that we make that available to our audience.
Yeah, and a primary care physician is well positioned for that because there's a dual message. We treat symptoms into remission. We care for person. They aren't the same thing. And it's often been said that if one person understands you, you don't feel alone.
Right.
And loneliness needs to be named as one of the big drivers of both exacerbating depression as an illness, as well as its own source of existential despair.
That actually touches exactly what I'm taking away from this, Lorenzo, which is you don't have to fix your patient. You just have to be there with your patient. You just have to listen and show up.
All right. Normally I add clinical points, but on this one we're going to close on that. So I want to thank our discussants in having a very meaningful conversation and taking what appears to be just a garden variety depression and really trying to probe and find deeper meaning in terms of resilience. So I think if you go through the case, you're going to see other clinical points, but I really want to leave with just this on that note because it's not something that we talk about frequently enough. So thank you very much.
Thank you.